Hi, welcome to week 3 of Intro to Practicum. This week we're looking at the how, what, and when of assessment. I use this acronym FIDO that we'll talk about for the first little bit to help give you some tools about how to know what information, how to get that information out from a client, and then how to utilize the information that you receive during your assessment process to develop your diagnosis and then your treatment plan. So frequency is the first element that we're looking at, because frequency really helps to give you a good picture and a great foundation for treatment planning. To understand how often this is happening, the presenting problem is happening with a client. Now we'll hear clients say things like, I'm depressed all the time, or he always does that, or she never pays attention to me. When we hear clients, this is their descriptor for frequency. So we want to take note of that, but we also want to use our clinical skills to help the client better define what they mean by I'm depressed all the time, for example. So we might ask the client, so tell me, what does that look like? You say you're depressed all the time. What does depression look like to you? Well, I stay in bed when I get up and go to work, but and on weekends when I get home, I don't want to do anything. I'm just staying in bed all the time. I don't even, weekends I may not even shower. So you'll use your clinical skills to hone in and help the client better define what it is that they mean when they make these statements. I like to help clients kind of break up their day. For example, I may say, how many times do you think she ignores you, Mom, before she goes to school? Is it 10 times before she goes to school? Is it, I always kind of shoot high, because it's easier for the client to go, no, it's not 10 times. That's only 35 minutes we're together. But she'll ignore me. I may ask her 5 times, have you got your lunchbox packed? And she'll ignore me, 2 or 3 of those times. Well, what about after school, before dinner, and that space between like 3:30 and 6 o'clock? How many times will she ignore you then? And then after dinner, how many times after dinner, before going to bed, does she ignore you? This really kind of helps the client, as you're interviewing them, break things down a little bit more into better absorbable pieces. It also helps the client, or the parent, if the IP, the identified patient, is the client, you're trying to understand what's going on. It helps them to reflect on their statements, and to experience, the problem kind of in real time. So that's the frequency. That's why we want to, where we want to begin working with our clients, is to understand the frequency of their presenting problem. So that's the F. The I stands for intensity. We'll often hear these vague descriptions or descriptors all the time, really bad. I've always cautioned people that are close to me, my children, my family, friends, to avoid these absolutes, because the reality is very seldom is an absolute going to be true. My husband is a jerk all the time. Well, if my wife were to say that about me, guess what I'm going to be able to do? I'm going to be able to point out the exception. So we listen for those descriptors and those exaggerations. Intensity is also subjective, as in really bad. That restaurant has really bad food. Well, the next patron may say, no, it's pretty good. And so intensity, we need to recognize as clinicians that it is subjective. And as we're listening, we don't want to just accept the subjective description of how intense it is or how frequent it is, but we want to slow down. We want to ask the client to better define, what's really bad for you in your relationship with your husband. You said it's really bad. What's so bad about it? And then help them look for those, exceptions themselves, because that will help them to begin to have a little bit of a cognitive shift. We want to do it in a way that we're not calling them liars, or in a way that they don't feel like we just don't believe them. We just want to do it in a gentle way that, can you help me understand when you say your husband is really mean all the time? What does that look like? The idea is to get a baseline. So we need to know, how bad is the problem now? Does it happen 5 times a day? Does it happen 20 times a week? And then compare that baseline of behaviors to a later point in time. Let's say 3 weeks from now, we've been working with a client, and in our baseline at intake, they said that the problem, the issue happens 5 times a day. But 3 or 4 weeks from now, we asked them, how often is that happening now? Well, it's only happening a couple times a week. Wow, what progress. We need to have a clear picture, and intensity helps us to do that, understanding the intensity at intake. Again, it goes so far in helping us to measure progress during treatment. If we get 3-4 weeks or 3-4 months into treatment, and the client feels like they're not making any progress, if we didn't do some baseline work looking at the intensity of the problem when they came into our office for the first time, then we don't have any data to help support encouraging them that, look at all the progress you have made. You started out, it was happening 5 times a day. Now you say it's only happening 5 times a week. You can use scaling questions. Use a scale. That's an easy way to understand, help the client understand the intensity on a scale of 1 to 10, 1 being my anger is a 1 when I'm not mad, and my anger is a 10 when I, wanted to run somebody off the road and I'm having road rage. On a scale of 1 to 10, on your average day, where is your anger level when you're driving? The client may say it's usually a 5 or 6, but it doesn't take much to get me to a 10. Somebody just has to cut me off in traffic. So using those scaling questions are a good way to help understand the intensity. So we've talked about frequency, we've talked about intensity. Now we're going to talk about how do we understand the duration of a problem. So with the duration, we're trying to understand the length of the behaviors when they occur. Does the client feel intense anger in short bursts, 5 minutes at a time, 20 minutes at a time? Or is it about 2 hours? Or when they get angry, do they stay angry all day? Knowing these differences, these very key differences, will significantly impact your treatment modality. the model you use to treat the symptoms are going to be significantly, you're going to make those decisions in large part by what is the duration of the impact once any of these emotions are triggered. You want to ask for details. Use timelines and calendars to assist a client in reflecting. I'll often have calendars, 12-month calendars, like from December 2019 to December 2020. And I may ask, okay, over the last 90 days, how many times have you gotten so angry? Has your anger been above a 6? Okay, over the last 12 months, how many times would you say your anger has been over a 6? So we're starting to look at some bigger chunks of time. You can break it down to the last week if you want. So we looked at frequency, intensity, duration. Now we're looking at onset. In mental health, research tells us that the median length of time that a client goes undiagnosed is 10 years. What that means is for 50% of people with a mental illness, they're diagnosed sometime within the first 10 years of having that diagnosis, that disorder. 50% of the other 50% of people are not diagnosed until they've had the disorder for 10 years or more. So think about that. How many people are walking around in our culture today, in our world today, and they have a mental illness that's just not been diagnosed yet? So it's important that we get this accurate picture of the client's story so that we can understand when the behaviors began. This is usually the easiest area for the client to identify, and it often relates to the reason why they're seeking treatment at this time. Maybe they first started experiencing depression when they were, 10 years old. Let's say maybe their mother or their father died, or a grandparent. So we want to know when the client started feeling depressed. Was it after the loss of a significant relationship? Or had they been feeling depressed for some time, and then maybe a minor incident was the straw that broke the camel's back, and it triggered thoughts now of self-harm. It's just intensified, and now they're thinking about self-harm. So we want to use these tools. We need to understand the frequency, we need to understand the intensity, the duration, and what was the onset of these symptoms. Now we're going to move into documenting our assessment. Documenting is like just painting this picture. Perhaps you, and I would encourage everyone to utilize a geneagram with a client so they could that helps them to begin to recognize patterns of negative interactive behavior, patterns of maladaptive coping. So this assessment, this picture that we paint with the client, the better we understand what they're experiencing, the more empathy we're able to feel with that client in the moment. And we know that when we're able to be empathic with the client experiences that empathy. That empathy actually is part of the joining process with the client, so that they feel that we really care, we're with them. We don't feel sorry for them, we don't have sympathy, but we have empathy. We can understand what it's like to be in the pain. Maybe we haven't experienced it, but we can feel the pain that they're experiencing. This allows us to hone in on our focus for treatment. It gives us an accurate picture of progress, again, throughout the treatment. I'm going to skip the piece about billing insurance, but we have to, if you're going to bill insurance companies one day, when you become licensed, you have to do good assessment and diagnosis and treatment planning. That's going to determine if you're authorized to be paid by the insurance company. The foundation of the work we do is assessment. It's a skill that you're going to continue to perfect over time. I've been doing this for many years. I'm still perfecting my assessment skills. Once you master, though, the art of FIDO, of how to assess the frequency, the intensity, the duration, and the onset, the act of writing out an assessment is going to be really much easier for you. So you have this clear information that you put into words, and this story will just begin to flow, and you'll draw this wonderful, comprehensive picture of why the client, how the client has gotten to the place they are today, where they came in to get help from you. I also recommend that you talk to your colleagues, to your supervisors, learn what you can from them. If they have other tools for gathering information, there's not just, in my toolbox at home, I don't have just one flathead screwdriver. I have different sizes of flathead screwdrivers. I have Phillips head screwdrivers. So you want to always continue to expand your toolbox. I'm so excited about the CU Well Counseling Center, because here you'll have such a vast, rich opportunity to meet with your fellow interns. You'll be working with Practicum 1, Practicum 2, Practicum 3 level students. You'll be working with the faculty and the staff. You'll be working with those who graduated from the program, have their associate's license, who are seeing some clients here. You may be working with some independent LMFTs, folks who graduated the program and are coming back to support you. So we really are our best resource for one another. So we've talked about how to do assessment, the FIDO. But when do we do assessment? Because assessment is not a one and done process. It's an ongoing process in psychotherapy. But there's 3 specific times that you reassess. The first is if there's a clinical change in their clinical presentation. Perhaps they've been coming in their mood's just pretty regular. They're not real happy, but not real sad. But they come into session, and all of a sudden it feels to you like they've hit rock bottom with their mood. You want to reassess when you see a change in their clinical presentation. You want to reassess when there's been a crisis. For example, if somebody loses someone that they're close to, they have, they experience something in life that because you know them, you've been working with them, you suspect that may have a deep meaning to them, a great sense of loss. And the third is if there's a change in a provider. It's difficult for clients to pour out their hearts and their souls and trust somebody as a clinician, as a therapist, and then that therapist has to move on. They leave the program. So those are the 3 times that we want to reassess a client. So let's move into the process that you're going to experience here at CU Well. The first session, or the intake session, you're going to go over the paperwork that you're required to go over, and you're going to have the client sign in front of you the informed consent. You're going to have them sign the observation and agreement to record sessions. You're going to go over with them the client information form that they filled, and you're going to go over the HIPAA Notice of Privacy Practices. 4 different forms that you're going to have them sign, but you're going to go over that information with them. This is where joining begins. You're explaining, you're not reading to them verbatim. You can let them know if you want to read that before you sign it, you're welcome to, but in essence, in short, here's what is in this paperwork. People really appreciate that. Can you think of the last time you went to a doctor and somebody went over the paperwork with you? No, they don't do that. They just hand it to you and say, read over this and sign it. We're going to go over it. We're going to go over, in particular, informed consent and limits of confidentiality. And we're going to particularly go over observation and recording for supervision notification document 2. And you want to, after you go over those documents, you want to spend some time going over the 4 pages of information that the client filled out. And we want to honor the time that they spent to fill that out. And there will be questions in there like current prescriptions and medications you may want to talk to the client about. Ask them, what does that medication? We're not medical professionals, so we don't have to know what the medicine is, but we certainly want to know why they're taking different medications. We want to talk to them about the family history. We ask them to list any major family health problems, alcohol or drug use. We want to ask them about previous counseling. So there's, again, 4 pages of information that they're pouring out their heart and soul. They're beginning to check this relationship with you. So you want to go over the client information to honor the work that they did to share that information with you. So I mentioned that even when we're going over the paperwork, we begin the joining process. So don't think that we're not working on joining with the client as we're going over paperwork. That's part of the art of what we do as clinicians, is how do we make this going over paperwork part of the joining process? Carl Rogers wrote a very fascinating article. You may want to look it up. It was in the Journal of Consulting Psychology. It's from 1957, where he identified that a therapist what they must do to create an alliance with a client. And somebody may have spoken about this prior to Rogers. I don't know. A lot has been written about it since, I know. But he said that we have to be genuinely engaged in a therapeutic relationship. He says that we have to have an unconditional positive regard for the client. And what does that look like? An unconditional positive regard. That means we value them as a human being. They're not just a client. They're not a means to an end for us. We're not just getting some hours in so we can get through our program. No, we value who they are. We honor their presence. We have to feel empathy for the client. I've discussed that. We have to clearly communicate these attitudes. So how do you do that? Well, that's the art of being a therapist. I can't teach that to you. You can observe it. You can learn to incorporate some of those perspectives, some of those values. In session 2, remember session 1, we've gone over paperwork. We began joining with the client. We're listening to the story. We're leaning in. We're not interrupting them. We're just present with them. Assessments already began, but we're continuing here in session 2. You've learned information from the client. Sometimes that first session can be so overwhelming because they have so much to tell. so much hurt that they've experienced. But hopefully you've been able to meet with your supervisor. Maybe you've been in group supervision. Maybe you presented on this client, the intake session. But you've hopefully, again, have made a hypothesis. What may be going on with the client? Maybe, from what I've heard from the client in that first session, I really believe that they're probably suffering from depression, for example. But in this session, you're going to use the DSM-5 self-rated level 1 cross-cutting symptom measures. And there's 3 categories. There's one for adults. There's one for children aged 6 to 17. And then there's one for ages 11 to 17. And so you will have printed off the correct self-rated level 1 cross-cutting symptom measure, depending on the age of your client. And because you've already hypothesized what may be going on, you may have the depression level 2 tool with you. I would encourage you to have several with you. My hope is that we'll have a cabinet in each therapy room that you can reach in the drawer and pull out as you need these forms. But after you've administered the level 1 cross-cutting tool, you're going to rate that. You're going to use the third page to look at what the T-score is, and then you're going to go on to the cross-cutting level 1 cross-cutting tool. We're not looking at T scores yet. You're just looking at, do they range moderate, mild, or severe, or they're not on the scale at all. In Dr. Bertram's class, Psychopathology, if you haven't had that yet, he'll go over that with you more. Your lead therapist, when you're in Practicum 1, will demonstrate on how to use these tools as well. I provide here a link. You can go to www.psychiatry.org, or you can just Google DSM-5 measurement tools, and it'll bring that up for you. So session 1, you've joined with the client, you've gone over paperwork, you began to develop a hypothesis what may be going on. In session 2, you've used some self-measurement tools to really narrow down and hone in on what the diagnosis may be. And by the third session, again, you've developed this therapeutic alliance. You began to join with them. You've heard their story. Session 2, you've used some assessment tools. And now you're going to use all this data that you've collected, ready to go into session 3 with your hypothesis, your diagnosis of the data. You've used the data that you've gathered, and you're going to share with the client, if you didn't do that in session 2, what your diagnosis is and how you came to that diagnostic assessment. You share that in the beginning of the session. Perhaps you finished it in session 2. You want to kind of revisit that and begin to do treatment planning with the client. For the purposes of treatment plan, this is really a guide. It guides the patient toward reaching their goals. Treatment plan also helps you to monitor progress and make treatment adjustments when necessary. It's a best practice to revisit the treatment plan every 3 months, and so that's something we're going to expect from you, is at least every 3 months you're reviewing the treatment plan to make sure that you're still on the right therapeutic path. If you think of a treatment plan as a map, it may help you to see it as it's a guide toward helping that individual experience a healthier condition in life. And without a treatment plan, a patient has no clear direction. You have no clear direction on how to help them improve their behaviors, how to correct or change negative thinking patterns or other problems that are impacting their lives. Treatment plan provides structure that the patient needs to change. Model and technique, the clinical things that you're learning in class right now, or you've been learning, those therapeutic models and the techniques that you're learning. Research tells us, and I'll give you the link to some of this research on this slide, says that model and technique only accounts for about 15% of the change that goes on in therapy. Research tells us that the focus and structure are critical parts of positive therapeutic outcomes. Focus and structure. Carl Whitaker made a statement. He was one of the early fathers in our field. He made a statement that I hold tightly to and I share with all the people I supervise. He said that the therapist has to win the battle for structure, and the client has to win the battle for initiative. Now, some people don't like that word battle, but I haven't thought of or figured out a more, maybe a softer word than battle. But think about that. The therapist has to win the battle for structure, and the client has to win the battle for initiative. What he means, what he's saying is, in that therapy room, as the therapist, you have to win that battle for structure. Let's say you're working with a couple and they can't even communicate with one another because their interaction is so toxic that they can't give each other the benefit of the doubt. They hear things, they assume if the other one says something like, that's ridiculous, that they're calling them ridiculous, for example. So you have to win the battle for structure in the therapy room. But the client has to win the battle for initiative. You cannot work harder than the client does. And that's something that you're going to have to learn. You're just going to have to experience, because in the beginning, as we're learning in this field, we so desperately want our clients to be successful. We want to help them experience life differently. So oftentimes young clinicians will work so hard, so desperately hard, harder than their clients are. And if we are working harder than our clients, we're not helping our clients. So what is the purpose of a treatment plan? Well, we're setting goals. That's part of the treatment plan. And just setting goals in itself is beneficial. Setting goals helps our patients to really achieve more, to stay motivated, to feel satisfied, to boost their self-confidence, to concentrate better. It avoids confusion. Goals are our roadmap. Treatment plan is our roadmap. It helps them to avoid feeling overwhelmed. It helps them to set priorities. Imagine a client coming in and they know that their goal is to be able to stand up and do a presentation at work so I can advance my career. And if we don't have a clear process, goals and objectives, that roadmap to help them incrementally get better, to manage their anxiety, how are they going to know if they're really getting better? That flood of emotion can keep them stuck in this place of feeling overwhelmed. But by having clear goals and objectives, That in itself is so therapeutic for a client. Treatment plans also help therapists and other staff with documentation. Treatment plans contain essential information about the patient's progress, and it's organized, it's clear. We're given details such as dates and names and measurable goals. A lot of people in the field use SMART goals. I'm not going to go into that in this session. We'll talk about that in another week. But with this information readily available, it's documented, and we're writing clear progress notes. Those clear progress notes are really guided by our treatment plan. Treatment planning is a team effort. It's something you do with the patient. Therapy is not something we do to clients. It's something we do with clients. We're not the experts sitting up on some ivory tower and imparting our knowledge and wisdom onto our clients. No, we're walking with our clients week by week by week. And it begins with the treatment plan. We don't develop treatment plans and give to our clients. It's something we have to collaboratively with them. Some examples of goals may include things like the client will learn to cope with negative feelings without using substances. The patient will learn how to build positive communication skills. The patient will learn how to express anger toward their spouse in a healthy way. I linked chapter 5 of a document that I found is linked there at the bottom of this slide. An objective, we have our goals. We just shared 3 examples of goals. But up underneath the goals are our objectives. It's the stepping stones. The objectives are the stepping stones to be able to reach the goal. And so these are specific skills that the client's going to learn. Objectives are measurable, and they give the patient clear directions on how to act. A few examples of objectives would be an alcoholic with the goal to stay sober might have the objective to go to meetings. If you're working with somebody and they start going to AA meetings or CR meetings, that might help them to begin to work on sobriety, may it not? A depressed patient might have the objective to take their antidepressant medication with the goal to relieve depression symptoms. Or a patient in recovery, they may have the objective to keep a daily assertiveness log with the goal to learn healthy communication goals, or healthy communication skills rather. An objective, very simply, is a specific way to reach a goal. Counselor might use their skills to help the client establish the best goals and objectives for their unique situation. Sometimes we have to lean in and maybe help the client a little bit more than we do with other clients, but we never want to be directive. We don't want to be telling clients what to do. That takes away their power. We never want to take away our client's power. We can ask ourselves questions to maybe help uncover goals. Asking our clients open-ended questions will help them discern what they need. Questions like, what are you doing right now that's unhealthy? I'm sleeping too much, I'm drinking too much. So you want to ask those open-ended questions. You can ask the question, what do you need to do differently to change this unhealthy behavior? You can ask the client, what do you need from me to help you? Once you realize your goals, how can you determine that you're really making or have made the progress that you want to make. You can also ask yourself these questions, but I prefer first to defer to the client. Asking open-ended questions will help them come up with their answers that they need to come up with. Patients play a very important role in developing their treatment plan. Although you use your professional knowledge to facilitate treatment planning, patients must participate in the following ways. They have to understand first that they have a problem. We can't provide treatment and do treatment planning with somebody who doesn't realize that they have a problem. They have to understand what their problem is and how it affects them. It goes back to the assessment work you're doing. And they must be willing to learn some new skills, new ways to solve the problems that they're having in a healthy way. So hopefully, I know there's a lot of information. You can go back and review this recording again. I will also provide you a link to the PowerPoint itself. If you just want the PowerPoint, email me and I'll send that to you, okay? So hope you have a wonderful week, and I'll talk to you next week for Module 4.